Morning, everyone. Morning. Just setting up. Kia ora. Morning. Just checking to see that you can hear me. Hopefully you can hear me. Morning, Bon. Hope you're feeling better. Well, I'm tuning in from Titahi Bay this morning. My name's Dr. Diana Kopua. I'm an independent psychiatrist, a doctor who is a fellow of the college, the Australia-New Zealand College of Psychiatry. Myself and Mark are the manukura, so the co-directors, the manukura of Te Kurahuna team, and we have a position on the classification system that we currently use in Aotearoa, the Diagnostic and Statistical Manual, and our position is that it's harmful to our people. If you look at the statistics, it's harmful. If you look at the whakapapa, it's harmful. And now, and it's time for Māori to reconceptualise concerning behaviour and distress. For those people who it's helped, morena, yeah, well, welcome, cool. Sit back and enjoy. We'll be here for the next 15 minutes. So our position statement is that we need to reconceptualise distress and concerning behaviour, and that will help us transform not just the mental health and addiction system, but all of the health system and outside of health system where mental health actually should sit, I believe. I've been doing these readings about this book by Dr. Joanna Moncrief, a critical psychiatrist, Atamari Aroha. And yesterday I didn't realise until the day before yesterday that it was the following day that I'd be in Wellington doing a presentation to the ACE conference, and that was fun. Pali's a great MC, and I'm hoping it's going well. Today's their second day, and I put some of these challenges to them, and it seems that they received them well. We are up to Chapter 3, The Importance of Research. We're looking at psychiatric drugs and the truth about how they work and how to come off them. And I like that Joanna is talking about how we consider them. She's referred to an alternative model at looking at psychiatric drugs rather than a disease-centered model, a drug-centered model, so that we know that these drugs, when taken, alter our minds, our mental state, and that's for all of us, not just people in distress with concerning behaviour. She's gone now into talking about randomised control trials, which actually are the gold standard, but she's talking about some of the problems with those. And now we're looking at, and she looked at the analysis and presentation of trials. So I think that's where we got to. I forgot to check this morning, so I might be doubling up. Let's see. And I'm at Tanya's house and she doesn't know I'm here, so she might interrupt and wonder who's talking from this bedroom. Okay, analysis and presentation of trials. As I've previously noted, one way to distort the findings of drug trials is to suppress the publication of negative studies. But the results of trials that are published can be massaged in numerous other ways to inflate the effectiveness of drugs and play down the adverse effects. Most studies look at several different measures of outcomes and published reports. Most of those studies often emphasize the measures that show the drug in the best light. Exactly how this is done and how it can convey a misleading impression was revealed in the case of an antidepressant trial known as Study 329. The trial was conducted and funded by GlaxoSmithKline, GSK, makers of the antidepressant paroxetine, and compared the effects of paroxetine with an older antidepressant, imipramine, and placebo in adolescents diagnosed with depression. The published report of the trial concluded that paroxetine was generally well tolerated and effective for major depression in adolescents. This conclusion is undermined, however, by the contents of internal company documents that would usually have remained secret but were released to lawyers in the course of a lawsuit. These documents showed that the two outcome measures that were originally designated as the primary outcomes and all 6 secondary outcome measures showed no difference between both the antidepressants and placebo. Wow. So there's these documents that aren't released, and what's published is that it looks good, and then we find out that there was no difference. So remember that study, whānau, that's study 329. And it's not until a lawsuit started that we found out about that. The documents revealed how these outcome measures were replaced by other definitions of outcome that showed the antidepressants to be superior, and that these were selected after conducting multiple tests in what is sometimes referred to as a fishing expedition. The draft paper that was initially submitted for publication did not include the results of the original primary outcome measures at all. Wow, so we can be all about outcomes, but if the outcomes don't show the picture that we want, we'll change the outcome. These were eventually added back into the paper in a table at the insistence of a reviewer, but there was no mention of them in the text, which focused instead on the replacement measures. The researchers who obtained the released documents pointed out that the way the company had massaged the results had led to the study being considered as a positive study when it was, in fact, negative. They conducted that flaws in industry-funded research can be severe and difficult to detect. Given that we do not usually have access to internal drug company documents, it is impossible to know how much other research has been distorted in this way in the process of publication. Remembering that as a doctor training to be a psychiatrist, I had to read these publications, and you have to trust that what is released is measuring primary outcomes. And if the methodology changes, it has to be noted in the publication. The way data are analysed can also affect results. For example, classifying people as either responders or non-responders may give a false impression of actual findings. Studies frequently report that what looks like an impressive difference in participants' response to a drug in comparison with placebo, when the difference on the symptom rating scale is minuscule. Terms like response are misleading, however. There is no natural division between people who respond to antidepressants and those who do not. Definitions of response are simply calculated from people's scores on the rating scales that are collected during research assessments. Classifying people into responders and non-responders is done using an arbitrary cutoff point that classifies everyone who scores above a certain level as a responder and everyone below as a non-responder. In depression studies, for example, responders are frequently defined as people who show a 50% or greater decrease in depression scores over the course of the study. Anyone who shows less than this is classified as a non-responder. Yes, aroha, mamairawa. Man, it's it's not okay. Anyway, anyone who shows less than this is classified as a non-responder, yet there is no reason why a 50% decrease in scores should divide people into different categories of outcome. When you compare groups of people, such as people allocated to a drug and people allocated to a placebo, very small differences in rating scale scores can translate into fairly substantial differences in the numbers of people classified as responders and non-responders. This is especially likely to happen if most people's scores are clustered around the cutoff score, which often occurs. So, dropouts from trials. Many people who enroll in drug trials drop out before the end of the study. In other words, they stop taking the allocated treatment, they stop attending assessments, or they relapse and are taken out of the study. The reason this is a problem is that we do not know the ultimate outcome for this group of people. For example, an individual may drop out in a period of crisis and appear to be doing badly on their allocated treatment, but then subsequently improve. In a case like this, the data obtained for the purposes of the trial will not provide a good assessment of how this person fared over the total period of the trial. In addition, if people allocated to the active drug drop out for different reasons than people taking the placebo, this may unbalance the outcomes of the final groups and influence the results of the trial. Just letting you know that at the end, toward the end of a publication, they are meant to talk about things that they couldn't measure and things that may have interrupted their study. And so they do try and account for this. Interpretation of drug effects. Randomized control trials are currently designed and interpreted through the prism of the disease-centered model of drug action. The main outcome measures consist of lists of symptoms, and if these are decreased in intensity by a drug, it is concluded that the drug has helped reverse the actual condition. The mental and physical alterations produced by the drug are considered simply as side effects, and the way they are likely to interact with symptoms is not considered. Yet, as explained in Chapter 2, these effects inevitably change people's experience and behaviour. Some antidepressants, for example, especially the older tricyclic antidepressants, have sedative properties. They may help people sleep, they may reduce anxiety or agitation, and they may simply make someone feel so groggy that they no longer feel depressed. All these factors may be interpreted as an improvement in depression, but none implies that there is any real change in the individual's underlying emotional state. Moreover, although drug-induced alterations may help reduce or obscure symptoms, they may make other aspects of people's lives more difficult. An antipsychotic may lessen the intensity of someone's paranoia, but sedate them so profoundly that they cannot carry on with their day-to-day lives, for example. An antidepressant may dampen down depressive feelings and improve scores on depression rating scales, but if all feelings are blunted, including happiness and love, people may find themselves worse off than they were before. Trials that focus on the results of symptom scales without considering the overall impact that a drug has on a person's life do not tell the whole story. Oh, shall I read the next bit? What's our time? Shall I? Not sure. I'll give it a go. Drug-centered evaluation of drugs. Taking a drug-centered approach to understanding the action of psychiatric drugs does not mean the randomized trials are useless or unimportant. Indeed, randomized trials are crucial in determining whether the alterations induced by particular drugs are helpful or not. But we need other sorts of research too, little of which is currently carried out. We also need randomised trials to be designed and conducted in a way that takes account of drug-induced alterations and their impact on the symptoms of mental disorders. In fact, the drug-centred model of drug action demands a whole new orientation to research on psychiatric drugs. First, we need much more comprehensive data about all the changes that drugs produce in our biological and psychological states. We need data from animal studies and volunteer studies about how drugs change normal behaviour and subjective experience and how they affect different bodily systems, both in the short and after longer periods of use. Then we need research to explore how those changes might interact with the manifestations of mental health problems and impact on the wider lives of people taking them. In considering how changes induced by drugs might be put to good use, it is essential to recognise what sort of changes our current range of drugs can bring about, and equally to understand what they cannot do. It is important to clarify exactly what people are trying to achieve through the use of drugs and whether this is compatible with the sorts of effects that drugs can produce. So any of you doctors or health professionals out there need to understand what is it that they want the drug to do, and often, and this is happening even where we're training people to be Mataora, we're not goal-centred. We focus so much on ridding a symptom that we actually are putting sedatives in people's bodies to rid the symptom, but it's not improving a quality of life, and it's definitely not achieving a goal if a goal has not been arrived at. And what I often say to the people that we're working with, you literally are shooting darts at the universe, and people stay on the medication so that the symptoms don't come back, but the quality of life is reduced because they often report that they cannot feel, they cannot experience a true karia roto. In particular, we need more data on what happens when you take drugs for years, as most people taking psychiatric drugs typically do. We also need further research on what happens when people stop taking these drugs. How significant are withdrawal symptoms and withdrawal-related adverse effects, and how can they be minimised? We also need to consider the moral aspects of using drugs that modify emotional states and behaviour. The sort of behaviour and emotional changes that drugs produce in different situations may be a scientific question, but the drug-centred model highlights that there is also a moral question about whether these changes are desirable or not. There are some situations in which different parties have different views of the value of drug-induced changes. The tranquilization produced by antipsychotics in someone who is disturbed and aggressive may be welcomed by members of the staff on a hospital ward, for example, but it is often intensely unpleasant for the individual. Indeed, one study found that when asked about their experience of rapid tranquilization, recovered patients said that they would have preferred to have been physically restrained than drugged. Similarly, the behavioural changes produced by long-term antipsychotic treatment may be valued by professionals and carers, but disliked by the individual. There may even be disagreement about the desirability of psychotic symptoms. Some people report that these experiences can be exciting or spiritually enhancing, while most professionals view them as undesirable. For this reason, it is important to clarify the exact purpose of drug treatment in every situation and the aims of all the parties involved, including the person taking the drug. If the primary aim of treatment is to make someone's behaviour less risky or less inconvenient to other people, careful moral and legal consideration is required to consider whether this is a legitimate goal or not. In the following chapters, Joanne is going to describe what is known about the global effects that different psychiatric drugs induce, using what evidence currently exists. She will then provide an overview of existing research on the benefits of drugs, bearing in mind that it was mostly conducted from a disease-centred point of view, as well as other limitations set out above. I will also consider, or she will also consider, the evidence on major adverse effects. I will then discuss benefits, what benefits might be obtained from the use of the different sorts of drugs in the various situations, and what considerations might be involved in deciding whether or not to use them. There you go. We're up to chapter 4, talking about antipsychotic drugs. So I will tune in tomorrow. I do have to say, yes, the name of the book, I'll read backwards, is A Straight Talking Introduction to Psychiatric Drugs, the truth about how they work and how to come off them. Now, the book's not that expensive, I don't think. You can get it on Amazon, and it's a part of a series. There are another couple of books that come with it as well, which maybe we'll get to read. I have to say, I really channeled a particular person who I used to work with when they talked about some people liking their experiences and that they find them exciting and spiritually and enlightening and lifting. And there's a particular patient or person that I worked with when I was a nurse for Central Wellington. And she came through really strong then, and I just felt like crying. And she used to have these voices, and they were Ernie and Bert. And one of them, that was probably Bert, was the sensible one. And Ernie liked gambling. And Ernie would help her gamble, and Bert would growl and be the parent in the relationship. And I really loved connecting to this woman through understanding her story through the Ernie and Bert analogy, because I had a history of loving Ernie and Bert, right? So yeah, I agree that people have these experiences, and us as professionals see them as problematic, and I'm sure that gambling was problematic. But she didn't like being put on medication. She didn't like her injection. And I cried because that was me. That's what I did. Right, sorry. She really distracted me. It was a great distraction. Kia ora aroha. Very mamae. Morena Rihanna. Take care, everyone. I'll see you tomorrow.